Right. Well, welcome to this week's Cancer Center Grand Rounds special COVID edition. You also see on the screen Dr. Alex Sekulik, our Cancer Center Director here in Arizona, Dr. Allison Rosenthal, the co-director for Cancer Center Grand Rounds, and our guest of honor, Dr. Gregory Poland. I think it's, I'm not sure Dr. Poland needs an introduction, but I'll do it anyway. He is beyond what you'll see on the introduction screen. Dr. Poland has been the leader of the Mayo Clinic vaccine group for 30 years, been continuously funded during this time, has advised multiple political administrations, has served on every advisory panel imaginable, both government and in industry, and is just is one of the premier subject matter experts on this topic in the world, and on top of that, just a terrific human being and a great colleague. So we really appreciate it. We had you, Dr. Poland, first time about 50 weeks ago. I think it was the first Thursday in September, and it just constantly changes. And so what happened is, with all the changes in Delta, there was so much demand from the staff and the faculty that, and we appreciate you making the time, because we know there's a lot of demands on your time. Yeah, so thank you.
No, it's a pleasure and always a privilege to talk with our colleagues.
All right. Well, I'm gonna give you the screen and turn my video off here. Is this showing the?
Yeah, not sure it's in presentation mode though.
Okay, so I have I'm sharing the wrong one. Let me do this again. I have two monitors up here, so this is the one. Is that looking the way?
There we go. Yeah. Okay. Yeah. So, you know, I decided to call this, and those of you that listen to the Mayo Q&A podcast have heard me say this. I decided to name this the ongoing COVID-19 pandemic. Everybody's aware of this, but they may not be realize that we are now in the most dangerous phase to date of the pandemic. And that's particularly true for people who are unimmunized. My next slide is just disclosures. If we could go to that slide. Basically try to assist all the Western manufacturers in regard to development of COVID vaccines. They depend on academia to help them. Next slide. So I've studied RNA viruses and vaccines for getting on 36 years. This is, what should we call this? A trigger warning? I'm going to tell you the blunt truth based on the data available. And in our current culture, truth is often not welcomed. And for some, it's upsetting. And that's because the truth is not beholden to political, religious, or economic conflicts of interest or misinformation. And this fundamentally results to what I call the hypocrisy of human behavior. I'll give you a brief example from one of my colleagues yesterday who admitted somebody with COVID to one of our units. And this is a person who had rejected masks, rejected vaccines, thought this was all a hoax, rejected the science. And on admission to the unit, transfer there, he happened to mention to the admitting physician, I want everything done that science knows to do. And I thought that's a perfect example of the hypocrisy of human behavior. Next slide. So the story of this pandemic will depend upon two, and really only two things: human behavior and viral behavior. We only get to control the first factor, of course, though it influences the second, as we'll see. You've heard the old saw, we've met the enemy and he is us. We have given up as a nation and as a globe the ability to have controlled or even eliminated this virus. And as we talk, I'm going to try my best to help you separate fact from fiction, because your life and those of your loved ones and those around you depend upon this key skill. Next slide. So unavoidably, we are flying the airplane as we build it. And yet we have to make decisions in the midst of the raging fire we call the pandemic in order to decrease deaths, hospitalizations, the demand on the medical system, et cetera. We have to protect ourselves and the many others who are not able to protect themselves. And I have to keep varying these numbers. Now it is 1 out of every 512 Americans has died of COVID-19. Not equally distributed, of course, but just to give you a number, we're getting toward 1 out of every 500 Americans has now died of a disease that I can pretty much prevent with a 25-cent mask. Next slide. So no one modality in and of itself is sufficient to end the pandemic. That's because we don't have anything, whether it's a mask, a vaccine, any modality, that's 100% effective. And so we speak instead of layers of mitigation. I liken it to driving your car in safety. It starts with good tires. It starts with obeying the speed limit and traffic control signs, brakes. Then we went to seat belts. Then we went to front driver bags. Then we went to side driver bags. Then we went to radar collision avoidance. And now we're talking about autonomously driving cars. The same is true with a pandemic. So everybody should get a vaccine that can get one. Everybody should be wearing a mask. Even in a place like Rochester, it shocks me. You go to the grocery store, there might be 4 of us in masks. Incomprehensible. And distancing. And because we haven't done that, we are going to continue to see the evolution of viral variants. We have watched this happen as predicted for the last 18 months. Some of these are developing the ability to evade at the current time in part, but in the future, potentially in whole, vaccine-induced and previously infected, that is convalescent immunity. Next slide. So this is just one example to give you a visual graphic, and I didn't have one before July 5th, but around about that time, there began to be some hot zones, if you will, of Delta transmission. Just to show you what exponential spread looks like, in about a month, we're looking at 90+% of communities now being in the substantial to high community transmission rate. It happened that quickly, despite the fact that we're, in the 60 plus to 70 plus in some communities immunization levels. Next slide. But of course, this is because of distorting factors, primarily around human behavior, vaccine hesitancy and rejection, anti-masking, political and economic conflicts of interest. And one I find interesting is a lack of businesses. They're afraid to mandate what they know would protect their workers. They're afraid to mandate masks.
You're frozen, Dr. Poland.
I am?
You were, I think. Right here at lack of leadership and fear.
I'm not sure why. Can you hear me?
Now I can hear you. Yeah.
Hello?
All good
Yeah.
now.
Yes, good now. Good now.
Okay.
Good now.
We suffer culturally under the false presupposition of what I call the democratization of expertise. That is, everybody's viewpoint is equally valid. Well, that may be politically expedient or culturally expedient, but it is a cognitive distortion and not true. And finally, we are very much a country of cultural narcissists. That is, it's shocking to people to even suggest that we should be thinking we, not just me. Next slide. So if you look at vaccine hesitancy in the US, and this of course is not every country, but it is in order, it's somewhat shocking to realize that the only country more vaccine hesitant than us is Russia, who truly does not trust their government, and we're not far behind. So when you look at the unwilling uncertains, by definition, we cannot get to herd immunity against these highly transmissible variants. Next slide. So vaccine hesitancy, of course, spans the gamut from very legitimate concerns and questions that deserve to be answered to conspiratorial thinking. I'm sure you've all seen this or had people come up to you and ask questions that reveal that, to low complexity cognitive thinking, bandwagoning, which you can think of as peer pressure, fear, heuristic thinking, which are simple rules of thumb that we use to make decisions, magical thinking, we're going to wake up one day and this is all gone, and other motivations that are not science-based. Next slide. So my daughter and myself, she's a mental health and trauma specialist, and one of the designers here at the Center for Innovation in Rochester recently published this paper on how we might improve COVID-19 vaccine acceptance. And one of the key things that I'll just read that paragraph, we form our beliefs. And if you look at that list, facts don't appear in there. After forming our beliefs, what do? We defend, justify, rationalize them. And the point is, beliefs come first and the data second. And this is what psychologists call belief-dependent realism. And this is a cognitive bias that is very, very prominent in human thinking and has not changed as far back. I recently, for a graduate program I'm in an unrelated field, I finished my thesis and looking at how Reformed pastors and theologians in England during the Reformation of the 1500s and 1600s, how did they think about and reason in regard to the pandemic of their time, which was the bubonic plague? And I'll tell you that even though that was 200 to 300 years before the germ theory of disease, and I mean this in all sincerity, they did better 500 to 600 years ago than we are doing. In other words, we have learned nearly nothing about how to handle a pandemic on the public community side of things. Next slide. So what can we say about vaccines? I will tell you, after 4 decades as a vaccinologist, no vaccine has ever been studied to this degree and with the level of scrutiny that this has been subjected to, and yet freely acknowledge we will never know all that we wish to know. We've been using influenza vaccines for 7 decades, and as we're speaking, there are clinical trials looking at next generation universal flu vaccines. The point being that the science continues to evolve as it always does, and yet we have to make decisions, we have to make policy. But those decisions about vaccines and policy have to involve a careful consideration of data-based, not political, not economic, not religious, data-based risks and benefits at the time we're making those decisions. Next slide. So it gets really simple at this point. You get 3 choices. Let me say it again. There are only 3 choices here. You can get COVID infected, and if you're not vaccinated, I think many of us in the field believe you will eventually get infected. You can get vaccinated, or you can go into some kind of isolation / Howard Hughesian hibernation, which has its own set of risks. I suppose a 4th one could be every 90 days you get an infusion of monoclonal antibodies, but that's not very practical, and I didn't list it. Next slide. So I'm going to show you a few data slides, then we're going to do Q&A. Let me just show you what it looks like for people that are not vaccinated. So we'll take the reference age of 18 to 29, and just for kicks, we'll pick kind of the middle column, people 50 to 64 years old. So relative to 18 to 29-year-olds, and of course, this is at a population level, certain comorbidities could change this, but the risk for a 50 to 64-year-old who's unvaccinated is about a 4-fold higher risk of hospitalization, about a 35-fold higher risk of death. So if you look overall at the unvaccinated in the US, they're about 3 times more likely to get infected, 8 times more likely to have symptoms, and 25 times more likely to be hospitalized. I don't have a way yet to quantify the risk of so-called long haul symptoms. This is kind of the black and white, low complexity thinking that you hear. People will say, well, I had COVID, I did fine, I'm not too worried. Or I didn't die, as if that's the only important outcome. Truly, we are seeing patients, even some of our colleagues, who have life-altering persistent symptoms after COVID. And depending on the series you read and which symptom you're looking at, it can vary from about 30% of people who've been infected to closer to 90%, at least over the following 3+ months. Next slide. So looking at risks and benefits, this is a study done in Kentucky, and they looked at people who had gotten previously infected. And then they divided them into 2 groups, those that subsequently got vaccinated and those that didn't. And if you look at those who did and those who didn't, the odds ratio for subsequent reinfection was 2.3 times higher than if they had gotten vaccinated. Here's your answer to people who say, well, I already got infected and I'm safe. No, you're not. And in fact, while I can't quantitate it, we have plenty of anecdotal reports that the second infection with these variants can be more severe. Next slide. So this is the number of Guillain-Barré cases reported to VAERS per million in those who had gotten the Janssen or Johnson & Johnson vaccine. So I just wanted you to see the numbers here. If you look at the second column, you kind of see GBS cases by gender, by age. And on the far right column, you see the number of cases per million doses administered, just to give you kind of a rock in the sand to understand the numbers we're talking about. One thing I want to point out to you is, unlike almost every other country, our safety surveillance systems are sensitive enough. Look at females 18 to 29 years old to pick up a risk of 1 in a million. That's astounding. Next slide. Now, this is a little more complicated. So what I want to show you are benefits and risks. Remember, I told you that no matter what you choose or whether you choose, there are risks and there are benefits. This is the best slide I know of to balance those. So we'll go by column. On the far side is first which vaccine you got. You can see Johnson & Johnson in the kind of third row there, and down below the mRNA vaccines, and you see it divided up by male, female, and age. So what I'm going to do now is take you through benefits, the middle set of columns. So if you were to get a vaccine, here's the benefits you would receive. So I don't know, we're going to pick, because we're talking about Johnson & Johnson, we're going to pick the far right-hand side column, the highest risk of TTS, about 8 to 10 per million. So if you got the Johnson & Johnson vaccine, about 8 to 10, primarily women of that age group, would develop thrombosis with thrombocytopenia syndrome, okay? So what are the benefits? That's the risks. Now we'll move over to the leftward to the columns. Well, you prevent about 10,000 cases of COVID in that age group, 900 hospitalizations, 140 ICU admissions, and 20 deaths. So I ask you, which risk do you want? Which benefit do you want? Let's move down to the lower half of the graph and look at of the table and look at myocarditis on the far right-hand side. The highest level is in males 18 to 29 years old. Now, this kind of myocarditis, unless we're looking for it, often we would even miss it. And of course, it occurs with COVID infection, generally much more severely, but it has been seen in association with the vaccine. 22 to 27 per million doses in males 8 to 29. If they're admitted to the hospital, they're generally watched for a day or two and dismissed. So if we get the vaccine, what are the benefits? The myocarditis is the risk. What are the benefits? Well, prevent about 9,600 cases, 300 hospitalizations, 60 ICU admissions, and 3 deaths. Which risk do you want? You don't get to choose none. If you get vaccinated, there are some risks of the vaccine and a lot of benefits. If you choose not to get vaccinated or not fully vaccinated and not follow science-based recommendations, you run all of the risks of COVID. Next slide. So what about this Delta variant? Well, remember that the R0, the reproductive number for the original Wuhan ancestral strain was about 1.4 to 2. Well, this is what exponential looks like. Now, instead of an infected person infecting on average 1.4 to 2 other people, they're infecting 5 to 9 people. The viral loads with this variant are significantly higher. In general, about 1,000 to 1,200 times higher than with the Wuhan strain. And this has allowed for some mild to moderate evasion of vaccine-induced and convalescent immunity. The same is true with the Lambda variant. And for a new one, I'm sure you haven't heard of, because it doesn't even have a Greek letter assigned to it, the so-called B1621 variant, which was seen first in Colombia in January, and now composes about 9% of the cases being seen in Miami. It seems to be a more deadly variant. There's one outbreak in Belgium in a nursing home that killed 7 fully vaccinated people and sickened 21 others. Next slide. With children, where we didn't see much, thankfully, of hospitalization or death with the Wuhan strain, that is not true with the Delta variant. Kids get sick fast with this. There's been a significant increase in the number of children and adolescents hospitalized with COVID-19. I have to keep updating these numbers. Now in the past week, this slide's a week old, it's closer to 100,000 new cases in children and adolescents. If you look at the Oxner system, one of the so-called sister clinics down in Louisiana, they have 800 kids hospitalized in their system with Delta variant. Overall in the US, we're a little over 2,000 now children hospitalized, which is about a 27–30% increase in 1 week. Next slide. So I'm going to two more, I think just 2 more data slides here, maybe 3. Some of the best studies done are in the UK, and they have what they call the REACT studies. So they take roughly about 100,000 people and they swab them every week for a couple of weeks in order to get as best they can, a random picture of what's happening. So round 12 in May was the Alpha variant. Round 13, late June to July, was the Delta variant. If you look at round 13, they had a 0.63% positivity rate in those swabs, 4-fold higher than in round 12, which was Alpha. So when they looked at vaccinated and unvaccinated rate, they found a 3-fold reduction of infection among those who were vaccinated. So if you look at the overall population, if you were unvaccinated, your positive rate wasn't 0.63, it was 1.2. And if you were vaccinated, 0.4. The other thing that you hear a lot about is, well, why should I get the vaccine? Viral loads are the same, whether you're vaccinated or not vaccinated. Again, this is low complexity cognitive thinking among people who don't understand the complexities and nuances of this disease. So while one study did show that, actually two have shown that, what's important is other studies that are better study designs have not shown that. So in this case, the higher the number, the better. And this is a rough measure of viral load. So in the vaccinated participants, the CT value was almost 28, whereas it was 23 in the unvaccinated. Next slide. The HEROES Recover study, actually, it includes Arizona, is looking at just under 4,000 healthcare providers, frontline workers, essential workers, et cetera. Now, this was back before Delta, so these numbers would logically be different with Delta. So if you look among cases, among the unvaccinated and vaccinated, only 5 fully vaccinated ever tested positive. The rest were all unvaccinated workers. And so if you look at the vaccinated workers, they had a 40% lower viral load on average, a 66% lower risk of detecting viral RNA after more than a week, almost a 60% lower risk of fever symptoms, and what symptoms they did have subsided almost a week earlier compared to the unvaccinated. Next slide. The Singapore multi-center study, which was a retrospective cohort study, looked at diagnosis, what viral loads were between the vaccinated and unvaccinated. They were similar, but here's the key. The viral loads in the vaccinated very rapidly declined, whereas they took a long time to begin to decline in the unvaccinated. What about medical outcomes of importance? And you see the columns there, unvaccinated and vaccinated. Mortality rate in the unvaccinated, 1.5%, 0 in the vaccinated. MICU admission, 5.5% in the unvaccinated, 0 in the vaccinated. Need for supplemental oxygen, about 21% in unvaccinated, about 3% in the vaccinated. How about pneumonia? About 53% in unvaccinated, about 22% in the vaccinated. So clearly different medical outcomes. Next slide. So I've already told you about the Kentucky study. Let me tell you on the bottom about the Chicago study done at Rush Medical College. This looked at naive versus previously infected. Now, I'm going to step into some controversy here. Policy is that after previous vaccination, we wait 90 or more days, give 2 doses of vaccine. I'm going to show you data after 1 dose and 2 dose in the first row, which is naive people. They've not had infection. They've not had a vaccine. And then the second row, the previously infected. So at baseline, not surprisingly, the naive antibody titer was undetectable, whereas in the previously infected, low at 620. By dose 1, the naive had antibody levels of about 1,800. The previously infected shot up to 30,000. By the second dose, the naives went up to 15,000, and not much movement with dose 2 in the previously infected. Now, one of the key nuances here is more antibody is not necessarily better. What's better is higher affinity and avidity antibody, not just more antibody. So we can't tell you about outcomes from that, but I thought these were interesting data. Next slide. If you look at vaccine boost after infection, panel A is the original virus. Panel B is the alpha variant, so-called UK. Panel C is the beta or South African, and panel D is the gamma or Brazilian variant. So you can see after infection what neutralizing antibody titers look like. Then time occurs 1 to 12 weeks after infection. You see, as is always true, antibody levels drop pretty profoundly in a number of cases. But after getting a booster dose of vaccine, they pop up higher than they were after infection. So these are part of the data for why the recommendation that even if you've been previously infected, you need to get immunized. Next slide. So this is my last slide. The theoretical construct is this. So if you kind of follow along this timeline, you start at time 0 down there in the lower left-hand corner. And of course, you don't have any antibody or protective immunity. We try to build immunity quickly by giving doses of vaccine against the variant that the vaccine is built again. And you see that take a nice high rise up past the level of protection. As is always true, that wanes with time. And depending on the virus, we give another dose. We call it a boost, and it pops back up. Then it wanes with time, and along comes a new viral variant where you may, in fact, have to give a booster that's variant focused. You're all familiar with this because we do this every year with influenza vaccine. This will very likely be true with SARS-CoV-2. And then I think my last slide. I guess I included this just because Friday you heard about a third dose in the immunocompromised. So this has been authorized by FDA and the ACIP/CDC for those that are moderately to severely immunocompromised. And I think that's it now. So my summary is we are now in a desperate but unseen and barely noticed by the public race of variant versus vaccine, of ignorance versus knowledge, of disease versus health, and we're losing. To know is science. To believe one knows absent data is simply ignorance, and more often than not, dangerous. So I will end with that, leaving us about a half hour or so for Q&A.
Thank you so much. I think hopefully, well, we have lots of questions. I sent you a few in advance. We have some in the chat, but hopefully we're all on the screen now. I see Dr. Poland, I see me, I see Dr. Rosenthal, I see Dr. Sekulik. I think the number one question we got, I think it's safe to say by far, was adding up to more than all the others combined, was the Mayo Clinic study, Moderna, Pfizer, the difference in efficacies. Could you comment?
Yeah, sure. So I don't even really like calling it a Mayo Clinic study. It was done by an analytics company called Inference, for which there were Mayo Clinic investigators. And what they basically did, this is a retrospective observational study. So you have to, as scientists, we have to say, well, sometimes that can give us valuable hints, but it's generally a weaker study design compared to other study design. And they looked at about 50,000 people in the Mayo healthcare system, as I recall, in 6 or 8 states, something like that. So that was a strength. And they looked between January and July of 2021. So they began to move from alpha variant during that observation period toward and into Delta variant. Again, a strength there. So what did they find with Moderna? Well, the efficacy during that time period against infection went from 86% to 76%. Efficacy against hospitalization went from about 92% to 81% with Moderna. What about with Pfizer? Well, with Pfizer, the efficacy against infection went during that time period from 76% to 42%. efficacy against hospitalization from 85% to 75%. Now, those are numbers within the range of other studies we see, but definitely on the lower end. And this did not include J&J vaccine, by the way. So their conclusion was that the risk of breakthrough infection with the Moderna vaccine was about 50 to 60% lower than with Pfizer vaccine. I think there's some confounders in there that likely make that difference more exaggerated than what we've seen in other studies, but there it is.
And the follow-up to that question for many people is, as boosters become available, is there, and this is a tricky one, is there a preference of Moderna over Pfizer?
Yeah, so there has not been any expressed or policy preference for either one. One of the things people are thinking about is what's called mix and match, get a different, second or third dose than what I got in the first or second dose. There's very limited data on that. What data there are suggests a better immune response at the price of somewhat more reactogenicity. So the dilemma that we're in, and again, I always find this ironic, is people decide to do things where we don't have data. And when we try to get them to do things for which we do have data, they reject it. And so it's really a difficult situation. Nonetheless, we're in the position sometimes where we have to speculate or extrapolate past the data. And I think simple practicality and feasibility would lead me to say, I'm really not worried about which one you got first time and what we're going to give you the second time, because if all I have is vaccine B and you got vaccine A 8 months ago, I'm going to boost you.
Okay. I think the one, and kind of a follow-up to that, there's the issue of mixing, matching between like the RNA family, so to speak.
Right.
And then there's the issue of crossing over platforms.
Between platforms, yeah.
And while I believe there's AstraZeneca data followed by Pfizer that's not available in this country, there is about 5, 6, 7% of the country, including some workers here at Mayo Clinic, who chose J&J.
Yeah.
So there doesn't appear to be a roadmap for that segment of the population in terms of if they wanted to get a booster of any sort.
Yeah, this relates to the notion that we're flying the airplane while we build it. In other words, these issues have come up before we can even collect those data. I will say that J&J did do a 2-dose study. Haven't seen those results yet. And Samir, you're exactly right. In the UK, they did a AstraZeneca followed by a Pfizer mRNA, saw better immunity than 2 doses of AZ, but again, at the price of somewhat more reactogenicity. Nothing that would be clinically limiting, but just to note that.
Okay. We have a whole slew of questions, 17 in Q&A, but before we start getting into that, and then of course we came up with 24 questions prior, a lot of whom we covered. But before we get into this, Dr. Rosenthal, Dr. Sekulic, any questions, or should we jump into Q&A or?
No, just fantastic.
All right.
Fantastic presentation, and just go ahead with questions because there's a lot of interest here.
There's a lot.
Theme in there about kids in school, so I'm sure we'll get there.
I'm happy to stick both feet into the mire here, but kids in school. So again, as I told you in my first slide, I'm going to be transparent and blunt. In my mind, we are doing a huge experiment with the youth of this country. We're going to take the most contagious viral variant we know of other than measles. They're not able to be immunized. We're going to forbid them from wearing masks. We're going to ignore distancing, and we're going to crowd them together and watch and see what happens. Okay, so that experiment started about a week ago, and numerous school districts within days began to see deaths, started quarantining in the hundreds of numbers of children. There is nobody, I'm going to say this dogmatically, there is nobody who is expert in this area who think, you know what, that's a great idea to do. Now, other side of the coin, the tension is, no question, it's better for intellectual, academic, social development for kids to be in a school environment. So wisdom resides in, how do you do that most safely? Well, you make the teachers and the staff be vaccinated. You enforce proper masks worn properly, appropriate distancing, and use what we know about science to decrease the risk. You can't eliminate it, but you can decrease it to acceptable levels.
Sure. There's, I think the question has come up a few times here, and we also prepared these, vaccines. Obviously, we have two issues. Vaccines are approved for under EUA for 12 to 17. I think the latest data I saw is about a 50% uptake. Vaccines for 11 and under, we don't really have great visibility on what's happening here. It would seem that the data has been out there long enough for at least EUA.
Yeah. So what has happened here, this is, again, is one of those interesting things. I had the experience where I was in a room and a parent was railing on me as to why this is taking so long and why kids can't get the vaccine. Walked to another room and a parent grabbed me and said, why are we rushing this with kids? And, both can't be true, right? So what the FDA, so 11 to 5-year-olds is being studied. The FDA recently asked Pfizer and Moderna to double the number of kids in that trial and to increase the safety window of follow-up to 6 months. Remember that in adults, it was only 2 months. Why 2 months? Because we've never seen any vaccine side effect occur longer than 6 weeks after a vaccine. Guillain-Barré, as a matter of fact. Otherwise, vaccine side effects happen in minutes to days. But as a margin of safety in kids, they asked that it be extended to 6 months. So what does that timeline look like? Likely for that age group, and I'm sorry to say, because if I had little kids, boy, would I be pushing for this. But I don't think we're going to have a EUA for that group until most likely early 2022.
Wow. Maybe the last question along these lines, if you wanted to comment, you mentioned the UK React Round 13 report and covered that. And one interesting sentence in there was that school-age children aged 13 to 17 were 9-fold increase from round 12,
yes,
and were felt to be the driver of the Delta surge.
Thank you for mentioning that, Samir. It's an important point. We know that the force of infection, if you will, for influenza outbreaks are school children. That was not seen with the Wuhan virus. We began to see it with the Alpha virus, but remember, Delta is so much more infectious with such higher viral loads that we are, in fact, and the REACT study was a great one to make this point, we are seeing high levels of infection and transmissibility among children, unfortunately. So it really is important that we abandon what we thought we knew a year ago with the Wuhan strain and correct what we know based on Delta science.
And a question from Dr. Patel across the hall from me. Dr. Poland, how do you respond to patients claiming they want to wait for a full FDA approval for the vaccine? Because we do hear this all the time.
Yeah. I think that is going to happen, if not by the end of August, in early September. I will predict, I'm speculating here, that will have very little change in the vaccine hesitant behaviors that we see. I think that's a bit of a ruse. Why do I say that? Because we have, as I said, this has been better studied with more safety data and scrutiny than any other vaccine. And I often say to people that, say something like that to me, I say, will you allow me to ask you one or two questions about any vaccine that you've ever gotten? They can't answer it. And I said, have you ever taken a over-the-counter medication? Oh yeah, I've taken Tylenol. Well, how big do you think the clinical trials were for that? They have no idea, and they're shocked to hear that for most medications, you're talking about, single-digit thousands, not hundreds of millions as have now been given around the world.
Okay. I think Dr. Rosenthal messaged me a question, and I think it had to do, good question about, we have lots of staff here who are pregnant, and so, or lactating, and so can you make any comments on the safety of vaccines in pregnancy, what trimester if they're going to get vaccinated, and the safety in lactating?
Yeah. Really good question that deserves data-driven answers. And I'll just reveal that I helped my own son and daughter-in-law through this, and we're soon going to have our first grandchild.
Congratulations.
And so I scrutinized those data really carefully. Interestingly, CDC just moved from the vaccines should be offered to the vaccines should be given to women that are planning families, pregnant, and lactating. Why that movement? Because the data show no change in spontaneous miscarriage rates, no evidences of any congenital birth defects, and definitely data that show, particularly in the third trimester, that COVID infection for a third trimester pregnant woman is a very dangerous situation and can be dangerous for the baby. What are the benefits? Well, by getting the vaccine, you are transferring antibody through the placenta that will help protect that baby for about 6 to 8 weeks after delivery. And if you're breastfeeding, and I would encourage that, you're giving IgA secretory antibody to that baby at the portal of entry for this disease for the duration of time that you're breastfeeding. So my point is that we can enumerate all the benefits. We have seen no risks. So which one do you want is how I think about it.
Dr. Sekulik, I think, sent in a very good question that we didn't have preloaded, and it's with the changes.
How does Dr. Poland really feel about this?
Yeah, oh, that you're so ambiguous. So the question of as we get these mutations, they seem to be the ones we're concerned about are in the S1 subunit of the RBD, and then we read that Moderna had come up with a booster trial that was going to target some of these specifically in 1351. But as we talk about boosters, is this going to be exactly what we got in the past? And if not, are there plans to come up with boosters in the future that would be more targeted?
So let me just clarify a bit of terminology. I know I'm being kind of arcane here with vaccinology talk, but for the immunosuppressed that will get a third dose, that's called a late additional dose. A better way to think of it is if you're immunosuppressed, your vaccine series is 3 doses of an mRNA, whereas mine would be a 2-dose series. When you're giving a booster after the primary series, so what's being talked about for all of us, that would be called a late booster. If you're giving a booster against a variant, that would be called a variant focused booster. We do not yet have a variant vaccine under EUA, so that can't be used other than in clinical trials. It's what we need, in my opinion, but don't have. So the booster being talked about in the 2 former cases is the same vaccine that we got in our primary series.
Okay. Let's start running down these questions. If you already had COVID and are fully vaccinated, what are the chances of getting infected with the Delta variant?
If you are otherwise normal immunologically, and you would have no way of knowing this, and don't have a genetic predisposition, it's a topic I've written and published several hundred articles on. I think at this point, with the known variants, you are really in a very, very safe position compared to about anybody else.
Great.
That doesn't mean not wear a mask, because you could still have asymptomatic infection and transmit to others.
Perfect. You've kind of touched on this, but the question is, for those who receive the Pfizer vaccine, does getting a Moderna booster confer greater immunity?
What we can say is early data suggest higher antibody levels, but we want to be careful here. Higher antibody level doesn't necessarily mean better antibody. Mike Nusenvig at the Rockefeller just has a preprint study showing a dramatic increase with these booster doses, but lower quality antibody. So we've got to be really careful about that, and we need kind of the real world effectiveness studies, which we don't have yet. And I have a concern about with the a public health policy that delivers a booster to everybody. We know that it increases antibody level. We don't know that it reduces the risk of infection.
Why isn't Mayo's policy to require vaccination versus the opt-out? And
I think a question that has come up a lot, and I think it showed up in here somewhere, is kind of, there's a lot of people, maybe especially outside healthcare, who have heard now we have to get another dose, and they're like, how long is this going to go on? I'm not going to do this every 6 months. This is crazy. I'll take my chances. How do you think we make sure people understand that the third dose is not because the vaccine didn't work, that we just need some more time to get past this part?
You know, it's just, how would I think about this? If influenza wasn't seasonal, we wouldn't be giving a new influenza vaccine every year. We'd be giving it every 6 to 8 months. This is no different. The difference here is that we are because of the number of people not immunized, not wearing masks, and uncontrolled borders where people can flow in and out, visitors, business, et cetera, so easily. We're seeing the rapid development of variants whose behavior is fundamentally different than the original virus we were immunized. It's not that the vaccine isn't working, it's that the public's brain, in a sense, isn't working. If we had all gotten vaccinated, I don't think we'd be seeing this. It's because of the variants that are developing that we have to do this.
That's a good point. And I think obviously there's only so much we can get into here, but I'm sure you're very familiar with the Maryland study that just came out showing the mutational rate is inversely proportional to the vaccination rate.
Not surprising.
Yeah, which is exactly your point. This leads us into another question. I think it kind of gets us into what's the end game here? If the vaccination holdout and widespread no mask wearing, how do you see this pandemic ending, and what time frame?
Sure.
What will it look like? Will this ever become endemic?
I do not believe it will end. B, I tend to side with SAGE and the Public Health England experts who I think do some of the best work in this area. And their prediction is that we are on the verge of developing variants that may completely escape vaccine and previous infection-induced immunity, in which case we will start all over. We've watched this movie 3 times previously. We know how it ends. We've started the movie for the 4th time. If we're lucky, I think what will happen is that this is going to get very much worse, and then it will start to get better and hopefully devolve into something more akin to influenza. But let me just make an observation here. You're all familiar with the 1918 influenza pandemic. You may not realize that over 100 years later, we are still immunizing against vestiges of that H1N1 virus over 100 years later. More importantly, I think we would be, and we have been, very naive after 3 previous warnings where we had coronaviruses jump the species barrier to infect humans. Expect SARS-CoV-2 3, 4, 5, and who knows what else.
Samir, maybe I can jump with one question
please.
on this one, because I've seen it as a repeated theme in the questions.
Yeah.
Even if we were successful in changing the attitudes in this country and get vast majority of people vaccinated and wearing masks and so on, many of the variants came from elsewhere. How do we address this globally? As long as there's a reservoir of people where this can be passed on, it will endanger us here as well.
Yeah, a very keen and astute question. And you can see differences in response. New Zealand had 1 case and locked the country down for 3 days. You cannot get into a number of countries without being vaccinated, without having a test, and without being quarantined before you're allowed to walk around. In the US, we, by virtue of our policies, which I call economic conflicts of interest, they may be practical issues, but they're economic conflicts of interest that are driving policy. By definition, we can't reach herd immunity unless we get high rates of vaccination, high rates of infection at the loss of an unbelievable number of people. And then we add 4 million new susceptibles every year, plus whoever comes from other countries that is not immune. So it's a very, very difficult situation. And so, of course, people don't think it will happen to them. But if I said, look, we can shut the country down or 1 out of every 500 of you die, what would you choose? I'm not saying I know the answer. I'm just saying those are the real choices in front of us.
Yeah. Dr. Halyard has a question and comment.
So the last part of that, Dr. Sekulik, is the idea I think you were driving toward, which I would agree with. The sooner we get the globe immunized, the safer we all are.
And just a funny thing that you mentioned this thing before the last sentence, because my 13-year-old daughter, as we sit around dinner, we were talking about this, and she says, wait a minute, if everybody in the world isolated for 3 or 4 weeks, there will be no COVID anymore. I said, well, there's a solution.
Yeah. Absolutely. Human beings have undergone much more severe trials and been resilient enough to thrive in the past.
Dr. Halyard had a question, comment. She said, thank you. And she was hoping you could comment on data on death rates in underrepresented communities, specifically in vaccinated versus unvaccinated, or separated by comorbidities.
Yeah, this is a really important issue. I mean, as everybody knows, we've got real issues. I don't think there's a society that doesn't have issues with racism or various isms. It just seems to be a part of, unfortunately, human behavior. And no question, let me be, again, dogmatic here, no question that our communities of color have disproportionately suffered here. I think the positive side of the coin is that there is no reason that anybody in the US can't get a vaccine now. There might be a few so-called medical deserts. I hate to use that word to people living in Arizona, but you know, there are some places where there's no pharmacy, no hospital. I get that. But for the most part in America, within an hour, you can walk into a pharmacy or another location and get a dose of vaccine. In fact, kudos to the Navajo Nation. They have among the highest immunization rates of any, you know, definable group. So I think the other part of the question is, if particularly, let's take African American communities that have really suffered, if they get vaccinated, do they do as well as other vaccinated communities? Yes, they do, with the exception of underlying comorbidities and sometimes living conditions where distancing and even masking is not possible or practical. So you have to take that into account.
Okay. Next question. Although on that, I do want to give a shout out to my friend and colleague, Dr. JP Santiago, who is a physician in the Indian Health Service and has been very involved with that effort and has been faithfully attorney. And they have done a tremendous job in the IHS and deserve a lot of kudos.
Yeah, that's a chapter in history that deserves to be written.
Yep, they've done amazing work. Dr. Sproat asked a question. How should we approach quarantine for doctors who are vaccinated and testing negative, but have kids at home who are infected?
Yeah, we don't have a lot of great policy around this, but I will refer you to the Mayo Occupational Health. There's a website. There's a wonderful, it's about 3, 4, 5 landscape-oriented pages that take you through every nuance of every scenario to answer that. So refer you to that.
Right. Dr. Singh, one of the medical oncologists in Arizona, asked a question: why didn't Pfizer and Moderna cause thrombosis-like complications, presumably similar to J&J?
Yeah, good question. You know, the pathophysiology of TTS with adenovirus vector vaccines has been reasonably worked out and does raise antiplatelet factor 4 antibodies, whereas mRNA vaccines don't appear to do that.
Okay. We have a timeline vaccination question for young. I think you've covered that. You said 5 to 12, probably, unfortunately, not till 2022.
Yeah.
We've got the FDA.
I saw one question pop up. If you've had a previous thrombosis, which vaccine would you get? I would not get an adenovirus vectored vaccine. I'd get mRNA. I should say, and I didn't mention it in my comments, but soon, I hope, we'll have a yet 4th vaccine made by a company called Novavax. Again, full disclosure, I give advice to all of these companies, but the preliminary data that have been released show really superior antibody levels with much lower reactogenicity. So, you know, keep your eyes open for that literature.
Great. This is a question from Stephen Russell. What about original antigenicity and the utility of vaccine boosters to fight variants? We've kind of covered this. But...
Yeah, I think what's being maybe gotten at is the concept of original antigenic sin and the concept of so-called trained immunity. So the argument would go like this: if I'm training the immune system that coronavirus looks like, let's just take the tip of my pen here, and that's what the S protein looks like. And now a variant comes along that looks like the tip of my mechanical pencil. Those two tips are different. Am I creating a scenario either for antibody dependent enhancement of disease or suboptimal non or even neutralizing antibodies that will not abrogate infection? And I think that's a valid question for which we don't yet have data and for which we're going to have to consider with pretty much every new variant or new coronavirus that crosses the species barrier.
Okay. See a couple questions. I'm going to tie them together. From Stephen Russell and Bethany Davis. And so I think the question has to do with titers of neutralizing antibodies correlating to individual risk of infection. Should we be testing antibody titers to gauge for risk of our patients? And then two, if antibody titers are barely detectable, does that correlate with protection? There's a few questions, but they kind of all go in that genre.
So let me make a couple of comments. We sort of have three arms, generally speaking, of our immunity. The most immediate one, foreign invader, danger, respond right now, is the innate immune system. That's why after my vaccine, I got fever. Okay, that's an innate immune function. Then there's humoral immunity, or let's say generally adaptive immunity, that has itself two arms, humoral immunity and cellular immunity. So when we're talking about antibody, we have to recognize that we're only talking about one arm of immunity. Important because it is the mechanism by which we prevent infection. But in terms of how people do, cellular T-cell based immunity will likely turn out to be equally important, and we don't measure that clinically. The next point is that we don't have what's called a correlative protection. In other words, I can't tell you an antibody level above which you're protected and below which you're susceptible. There's some hints toward that, and it looks like that level is lower than we would have expected, but that was prior to the development of variants that are beginning to develop, epitope spreading, and mutations and deletions, and more importantly, not just mutation, but recombinational events. So we don't know yet. As soon as we do know, I predict that we will be rather routinely measuring that antibody level as a metric that might help us to individualize decisions about the need for a booster or when to boost. And I can tell you there are a whole bunch of companies lined up ready to provide those assays.
Okay. That maybe that's a good segue into a lot of us on this have patients on rituximab. As you know, CD20 shuts that down. And so those patients presumably are depending on T cells for their, so I guess if I'm following, they could get infected, but then the T cells should come in and kill off an infection.
That's what we would hope. And there are experiments of nature, so to speak, where one arm or another of immunity is not operational or functional, and people seem to do well and good. The problem is none of those individuals were represented in the phase 3 trials, and we don't have a national way of collecting those data. So, you go and look, and what you find are small studies. Even the solid organ transplant literature are studies of small numbers by individual center. So I think the key thing here is, based on this recommendation that came out last Friday, is, be sure that you talk with your healthcare provider to determine, do you fit into this moderately or severely immunocompromised categories in terms of getting a booster dose of vaccine.
Very good. Do you feel comfortable commenting on the role of mutations in the non-structural proteins coded by the ORF genes?
That's actually important. Full disclosure, we've been funded by an outside entity to develop a new platform of COVID vaccine, and one of the things that we're doing is including structural and non-structural peptides across different SARS-CoV-2 variants. And we think in particular, ORF3A may turn out to be important. The issue, of course, is a structural or non-structural protein ever seen, if you will, by the immune system? Even if it's not, there can be some reasons why it might be important. But I think the basis of the questioner's question is it likely that more than spike protein is going to be important? I think the answer is unequivocally yes. And in fact, published a paper a year ago saying that I thought the dependence on S-only vaccines was going to turn out to be limiting.
Very interesting. That's also another question from Dr. Santiago of the IHS. Smart question. There's a few questions having to do with travel. We are now entering a fall season of national meetings. I saw on one of the physician Facebook forums, physicians from Hawaii basically begging people not to travel to Hawaii for national meetings in particular, because of limited resources. Could you make some general comments on travel right now to national meetings in the fall, and should there be a pause?
Yeah, I don't think there's any question from a science point of view. I'm the chair of 2 annual international meetings, and we're going to do them virtually. I personally think that it's irresponsible to fly people from all over the world into indoor settings crowded together in the midst of the defining pandemic of our age. I just don't see it as justifiable. I recognize there are times when when travel is essential. I don't think a meeting is one of those when it can be nowadays so easily conducted online without risk.
Well said. Question to confirm, you said you do not have data to support higher antibodies support better immunity. I don't think that's exactly what you said.
Yeah, no, it's not.
There's a threshold level, but
yeah, there's a threshold level, and again, I didn't get into the nuances, but it depends on what antibody we're talking about. Are we talking about neutralizing antibody? Are we talking about antibody for which we've measured avidity and affinity and know that this is highly focused, high quality antibody? Or is it, as Nusenvig's group points out, often this is antibody raised against pseudoviruses and done a whole variety of different ways. Is this really antibody of higher quality versus quantity? And that's an active area of investigation.
Okay. Some question.
It reminds me of the old saw. There's what I said, what you thought I said, what you heard, what you told the next person, what they thought they heard.
Yes. Well, and we've covered a lot of ground here today. So, a couple questions from Dr. Sitaram, kind of related to one another. Dr. Sitaram is one of our medical oncologists focused on sarcomas, if you haven't met him. How long will it take to tweak the vaccines to cover the Delta variant or other variants? And is that happening? And will antibody titer-based booster strategy get worked out?
I think yes, in regards to the latter question. So Moderna and Pfizer are already in studies looking at variant-focused vaccines. So I think we will see them. The better approach is what I call a pan-coronavirus vaccine. And let's see, it was a preprint. Can I say anything here? It was embargoed. I think so. I think it was only embargoed till this morning. There's a New England Journal article looking at some of the immunologic basis underlying the possibility of designing a pan-coronavirus vaccine, which of course, that's what we're doing, and we think it is feasible.
What happens with the supply chain issues there? Because there was a reduction, obviously, there was a less of a cold chain requirement made as we learn more, but it's still not trivial or insignificant, especially for emerging nations. So is there a path forward to something that could be transported more easily?
Absolutely. So the one we're working on wouldn't require a cold chain, could be stored indefinitely. has no allergic or other contraindications. Two companies I'm aware of, and I applaud the approach, are working on an oral tablet vaccine. I actually think that's another key part, is the development of immunity at the portal of entry for the virus would be a key strategy to exploit. So oral vaccines, nasal spray vaccines, inhaled vaccines are all being looked at as next wave, probably third or fourth generation vaccines.
And this gets us into, again, there's so much you can cover on this topic, and you know, the breakthrough infections, as they're called, and rightly or wrongly, you have been talking about this for a year, and as I recall, this was always a theory because these intramuscular vaccines do not generate secretory IgA. It just took till Delta. Do we need an intranasal vaccine, or what else can we do for this secretory IgA to protect the mucosal associated?
Yeah, and that's what I was mentioning. You know, nasal spray, oral vaccines. There's I'm not sure this would generate secretory antibody, but there's some elegant approaches looking at transcutaneous administration. In other words, to simplify it, a Band-Aid vaccine. All of those, I think, are important. And what's interesting is, wouldn't it be interesting to have a strategy where you get one or two doses? Maybe your first dose is injectable, your second dose is an oral vaccine, and your third dose is a nasal spray or inhaled vaccine.
Brilliant.
You know, or something along those lines.
Perfect. Let's see here.